Morning, everybody. For those of you who don't know me, I'm Alan Lucerna. I'm one of the attendings here at Kennedy Hospital in Stratford. And today we're going to talk about geriatric neurologic emergencies. The lecture is done through the Reynolds Foundation, and this is basically a care of the aging medical patient in the emergency room. It's a lecture series that provides education to residents and attending physicians on how to deliver the most efficient and the most safe care to our elderly population in the emergency room. And we're going to start off with some questions. Which of this test is not part of the stroke evaluation in the E-Day? A, CT with contrast. B, acute check. C, ECG. D, cardiac enzymes. Or E, coagulation panel. So the correct answer is A. You actually do a CT without contrast. Okay, question number 2. When evaluating for potential thrombolysis, which of these criteria is an absolute contraindication to TPA administration in a patient who is in the 3-hour window? A, age greater than 80. B, platelets less than 100,000. C, glucose of 200. D, INR of 1.2. Or E, systolic blood pressure greater than 179. Please log in your answers. All right. So the correct answer is B. You have to make sure that basically your platelet count's above 100,000. Systolic blood pressure cutoff is 185 systolic. Okay. According to the recent published trials on the use of TPA in patients presenting in the 3 to 4.5 hour window, age above 80 is a contraindication. Please denote your answers. A lot of you guys put in as false. In the 3-hour window, there's no age limit. But ECAS trial has basically has stated that the testing that was done during the trial, they didn't have patients above 80. So it's under investigation. So the answer is actually true. So our topic today is basically, our objectives is to discuss the diagnosis, treatment, and basically explore the unique features common to the geriatric population as they present to the ER for an evaluation. Topics can include trauma, but most of the lecture today is going to focus on stroke. We're going to talk a little bit about subarachnoid hemorrhage, subdural dizziness, some infectious entities, meningitis, and epidural. This is very interactive. You can ask questions at any time. So let's talk about trauma. Overall incidence of traumatic brain injury in the ER is about close to 450 cases per 100,000 persons in the U.S. In the elderly, that's almost 3 times, about 1,026 cases in patients that are over 85 per 100,000. So as you get older, you can see that there's a dramatic rise in the incidence. And most of the time it's females. Subdural is the most common presentation, about 50% versus 28% in the young. For some strange reason, epidural hematoma is actually less common. And the elderly is prone to pedestrian accidents and falls. Anybody that works here in Stratford or in Cherry Hill, you've seen a lot of patients come in from nursing homes who have basically fallen from a standing height, brought in full spinal precautions in the ER. So with the falls, as you hit 65 or over, your annual incidence is about 30%. And that's basically increased to 50% in octogenarians. And the reason for this is multifactorial. There's changes as we get older. We have more comorbidities. We have some autonomic dysfunction. You're on meds that could produce orthostatic hypotension. A lot of entities. And all this in combination could basically predispose someone to fall. A lot of times there's also environmental, things that nobody's really addressed at home, the lighting's poor, there's carpets, that kind of stuff. But this is what you get a lot of times when family members come in. Like, how bad can it be? Grandma was sitting down in a chair, she got kind of off balance, fell down the side, or she was standing, she tripped, she fell. How bad is it, right? Gravity does not hit terminal velocity at standing height, right? So, compared to the young, as we get older, about 7 times more falls are the etiology of the injury, like 48% compared to 7% in the young. And 7 times more to be the cause of death in the elderly, but 55% versus 7.5% for the young. And what are these injuries? Well, same level falls actually result in about 30% of injuries overall in the elderly. And most of these falls are basically kind of head and neck, 47%. And the mortality is about 15%. Now this is overall. Does that not account for patients who come in with broken hips? And what's strange is that because of aging, the dynamics in the cervical spine has changed, where in the young, a lot of the flexibility is centered around C4, C7. With DJD, caused by aging, the mechanics basically is shifted, where in particular, C2 area, the odontoid is the most injured area. In one case series, actually, where they studied or looked at 149 patients, C2 injuries account for about 40% of the fractures. And in the lower cervical spine, they found about C5, C6, 12% fractures. And a good number of them also had multi-level fractures. So risk, basically DJD, osteopenia, is there to basically compound the fall. And as you can see, if you take a plain film view, 17% will not show any kind of swelling in the prevertebral space. Okay, so a lot of experts actually bypass doing a plain film, just go right ahead and do a CT scan. And what's very scary is that 3 out of 4 elderly who fall actually have a serious spine injury, have no symptoms at all. They might have, 2 weeks ago, there's somebody in Stratford who fell, moving in his neck like this. I don't have any pain, had an odontoid fracture, and that had to be shipped out. So the lesson basically is that low threshold for imaging, preferably a CT scan, low threshold for immobilization. How about pedestrian injuries? It seems like subdural and subarachnoid are almost there, but 30%. Mortality is close to 20%. It's advocated that these patients go to a trauma center where they actually have better outcome as opposed to if they go to community settings. So we're comparing about close to 60% versus 8% in terms of survival. However, at the scene, the older the patient, the less likely they be transported to a trauma center. As you can see there, more than half close to 90% actually, 80% of the young population gets transported to the trauma center as opposed to 60% of the geriatric population. And when it comes to traumatic brain injury, age is an independent risk factor basically for death. And even taking out all these comorbid conditions and complications, the geriatric population basically have poor outcome at discharge. Now we can move on to stroke. Do you have any questions at all in terms of trauma? Okay, I know it's just a simple overview. But I think the kind of the bread and butter when somebody says neurological emergencies, stroke is probably on top of the list when it comes to that, especially in a community hospital. So these are like the leaflets and the posters that a lot of stroke societies have disseminated in the, it goes in the gym, the schools, and basically it talks about like the FAST, okay, face, arm, speech, and time. So just to look at how bad this illness is, about close to 800,000 people suffer stroke, or recurrent stroke, in the United States per year. The majority of this, about 625,000 are ischemic. And basically by 2025, the annual number is going to reach 1 million. So in 2003, about 200,000 patients died from stroke. And it's the third leading cause of death after heart disease and cancer. Now if we go outside the United States, in Europe, it's going to have the same numbers. A third leading cause of death in the industrialized Europe. And basically the World Health Organization has estimated about 15 million will suffer stroke worldwide per year. And as you can see, the people aged over 65 will be 10% of the population by 2025. So that's going to be a big number in terms of people who are at risk. So why is it causing a lot of problems in terms of pathology? The brain basically is 2% of the body's mass, but requires about 20% of the total resting cardiac output to provide essential nutrients and metabolism. And any disruption of this would result to obviously what we call stroke. So seconds to minutes after that insult happens, there's a ischemic cascade that ensues, and the ultimate result is basically swelling and cell death. Now, at the core, there's a lot of brain tissues that dies right away. In the surrounding tissue, there's an area called the penumbra that actually has perfusion, but it's not enough to maintain a high metabolic rate. And it's basically an area that is ischemic, it's stunned, and it's viable that you could salvage it. And most of the targeted therapy is towards this, salvage of the penumbra. So in terms of mechanism, but 80% of strokes is ischemic, and that could be embolic, thrombotic, lacunar, or watershed. And watershed is like what you hear a lot. Patients that come in, they're not necessarily experiencing a stroke. They had a relative hypotension either in the OR or while you're intubating, and they get a stroke just because there is pre-existing lesions in the blood vessels, and they're at risk for it. And they're very, very sensitive to changes in the fluctuations of the blood pressure. Now, if you think about global terms, really the mechanics are, okay, there's an intrinsic disease of the blood vessels of the brain. They're blocked up or they're narrowed. It could be from the heart, get flecked off, goes to a blood vessel and clogs it up. Or it could be a decreased perfusion, or in people who are hyperviscous, patients with sickle cell, they can end up with a stroke as well. Or the piping in the brain basically ruptures. So kind of like a summary of what the mechanism is. So in terms of mortality and morbidity, as we already described, stroke is the leading cause of disability in the United States. But this is kind of like the rules of the 30s. But close to 30% of stroke survivors needs assistance with their daily living. And 30% of that have difficulties with walking. But close to 30% requires admission to long-term care. And about 30% of stroke survivors have depression, and as well as the people that take care of them. So not only is it physically impacting people, it's impacting people and their caretaker emotionally as well. And of course, the bottom line, right? What is the money issue? So you could see close to $70 billion is spent, or basically is the cost of stroke in the United States as of 2009. And so we talked about that the population of 65 or over is going to increase by 2025, 2050, and this cost is just going to go up. So how do we evaluate for stroke? As part of the EMS community, it is our duty to basically educate the people that are seeing these patients in the community and give them a criteria and triage at the site on what is needed to be transported to a stroke center or somewhere else for evaluation. So it's our duty to provide high-quality dispatch. Of course, ER, ABC, perform rapid stroke assessment. The most important thing is, when was the last time this patient is seen normal? And hopefully, all these patients get transported to a primary stroke center, if possible. So what kind of tools do they use in the field? They have the Cincinnati Pre-Hospital Stroke Scale, which basically just talks about facial droop, arm weakness, speech abnormalities, or the Los Angeles Pre-Hospital Stroke Scales. And a lot of times when EMS come into the ER, they will say, hey, what the Los Angeles is this, or Cincinnati is this. So this is what they're talking about. So why should they go to a stroke center and not just to some, hospitals, a general hospital? Well, Class 1 evidence from American Heart Association basically says that, they do better. Nurses are trained there, physicians are trained to basically evaluate these patients rapidly. They have CAT scanners who will be employed. They have stroke algorithms that are in place. So you have a 47-year-old female, presents to the ER for an evaluation of the right side weakness and dysarthria. Patient states that she's doing laundry, You notice she couldn't lift her right arm. Arrived at the ER with vital signs 160/95, pulse 89, respiration 20, 98.6, temperature 99% of room air, and NIH score of 16. What's the most important question? Time, right? Okay. So let's just say this patient kind of is obtunded, there's caretakers at the site. Always stress to the AMTs, send the caretaker along with the patient. Obviously if you can't ask the patient if they're obtunded, what time the changes have occurred. Okay. What do you guys think of that NIH score? Is that bad? Is that good? Is that anything? Okay. As we talked about, time. Why is time important? So every 60 seconds that we have ischemia to the brain, we basically damage close to 2 million cells. So the evolution of stroke is about 10 hours. As you can see there, if you have a full evolution of stroke without doing any kind of treatment, we basically accelerated your aging 36 years. As you can see, and you lose 4,470 miles of neurons. That's tremendous. And you can see, look at the minute by minute breakdown of things. Just per second, you're losing neurons at 32,000 per second rate. So basically, what happens is that stroke accelerates your decline in matters of minutes or seconds. 10 hours, so you lose 1.2 billion neurons, 8.3 trillion synapses. Okay, so sudden weakness of the face, arms or legs, sudden confusion, difficulty speaking, those are the kinds of things we look for. And one of the most important things is that as you triage this patient, you always want to ask, was there any headache? Is headache part of the ischemic stroke syndrome? Do you guys know? Okay. So what you're trying to triage is for subarachnoid or bleed, right? Okay. Is there any family history of aneurysms or any kind of history of stroke in the patients in the past? All right, what kind of stroke syndromes do we have? So just to go over quickly, in the anterior circulation, you could have a motor and sensory deficit, more so in the foot than the face or arms. It's kind of like a frontal release signs. You could have abulia. You guys know what abulia is? It's basically kind of like not able to do, kind of like a Parkinsonian thing where they don't want to initiate movements. You could get, have what's called gait apraxia. What it is that it has nothing to do with tremors, there's nothing to do with weakness. If you lay the patient down, they'll be able to do this walking with their feet, but then when you stand them, have them walk, they actually don't know how to walk. So, and then the grasp and sucking reflex are all frontal release signs. With the MCA distribution, if it's in the dominant hemisphere, you get aphasia, some sensory deficit. If you involve the internal capsule, you get that hemiplegia, and of course some visual changes as well. In the non-dominant hemisphere, you could have some neglect, motor and sensory deficits, visual problems. And in the posterior circulation, you could have also visual problems and what's called alexia, and that is loss of ability to read. It's kind of like if you're dyslexic, you kind of, that's before you read or you're starting to read and you can't read, but like alexia is basically loss of that ability that you had initially. And you could have some third nerve palsy. And if you go to penetrating blood vessels, like in lacunar stroke, you could have either a pure sensory or pure motor. You could be clumsy. And in the basilar circulations, you could have cross deficits, where you could have a facial involvement in one side and a contralateral deficit on the other side. And then if you have a internal carotid stenosis, you could have a stuttering syndrome, like an MCA type distribution. We talk about headache. That's a stroke syndrome that's kind of absent in patients with ischemic stroke, right? Actually, a small percentage actually do come with headache as part of it. So it's not true that it's solely bleeds. So less than 10% will have some headaches as well. So everybody talks about, oh, what's the NIH score? What's the NIH score? Okay, so there's a cutoff of things where you thrombolize or you don't, or just let it go. So essentially, if you ticked off all the boxes or there's some amputation in the extremities, it is basically 0 to 42. What is the average of patients that get lysed? 16. And then some literature would say that you don't lyse less than 5, and you don't lyse greater than 22. So why is that NIH score important? What it does is creates basically kind of like a standardized evaluation of the patient's initial presentation, and if there's any kind of changes along the way during the clinical course, they'll be able to duplicate that study and compare prior to the arrival. So, but does it do any kind of prognostication in terms of outcomes? As you can see there, if you're less than 60 years old, your about 3-month percentage of favorable outcome is about 18% if your scores are like 10 to 14. If you're 61 to 68 and you're 10 to 14, your favorable outcome is about 25%. As you can see, as you get older, this statistics or this changes basically dramatically goes down. Without even mentioning it, I know it's belaboring, but ABCs, that's core ER principle, right? The answer to every test is ABC. Okay? Question 1 is A, question 2 is B. Okay, but basically what you're trying to do is that reverse anything that could be done. So if the patient comes in with a stroke and they're basically hypotensive or hypoxic, you want to address that issue by administering oxygen, putting an IV in, and giving some fluids. You want to check the sugar, make sure that you're not giving TPA to somebody with a sugar of 20. Here in Kennedy, we have a stroke alert protocol where a guy comes in and you announce overhead stroke alert and he clears the CAT scanner. So if a guy is laying there, they will expedite the process for you to get a scan. And what do we test for? A few things I already mentioned. You want to put 2 large bore IVs. You want to check basically any contraindications to TPA. So as soon as the patient arrives and your NIH score is done, you want to run through the list of things so that while the patient's going to the CAT scanner, you're already on the phone, you're ready to go on the phone with a neurologist for a consultation. Always, always, if you're thinking about thrombolizing someone, get a type-in screen. Because you don't really want to stick someone with a TPA that's already given and somebody that's going to be bleeding. Okay, and this is a very cool slide that Dr. Scally had. So just a basic summary of what was said so far. In a field, signs of stroke is identified, EMS is activated, in the scene the established ABCs we mentioned, transported basically to the stroke center. Family that was a witness, be able to give history, is also sent. In the ER, you continue your evaluation, get an EKG, activate the stroke protocol and get your NIH scoring, get a CT scan. Does the patient have a bleed? If it's not, consider thrombolysis. While you're doing this, you're also evaluating serially, make sure that the symptoms are not resolving. Okay, and then if the patient still is candidate for thrombolysis, make sure you talk to the family. That's the most important thing. These are not benign medications, and obviously the bleeding rate is there. And if you just casually say, "Oh, this medicine is going to bust the clot," and the family's an impression that there's no risk, it could get you in the end. So if the patient is not a candidate for thrombolysis, you give aspirin. Now, obviously, if there's a bleed, you want to expedite transfer to a place that has neurosurgery. And then once you established in either you want to thrombolize or not, a disposition to the ICU for further testing. So what are the signs that we see on a CAT scan? You could have hypoattenuation involving one-third or more of the middle MCA. You could have loss of the lentiform nucleus. You could have dense MCA sign, which is pointed there. And what does that mean? What do all these things mean? Early signs of stroke. Basically, it means that the patient is probably not going to do well in terms of loss of function. However, these are not contraindications to lysis. As it says in there in the NINES trial, that basically the early signs are not really at the increased risk of bleeding when the TPA is given. So TPA in acute ischemic stroke is a level 1 care. And, people are getting educated now. They all go on the internet. Even grandma goes on the internet. They know what their trials are out there. A lot of these people sometimes know more of their disease than you. And look at all these drugs before they even come in. They're very, very informed. Wherever you are going to be practicing someday, the population that surrounds your hospital could be one of those that are very, very highly educated. So the decision for you to TPA someone might not be solely yours. So when do we give the TPA? So patients now have to be present within 4.5 hours of symptoms. And obviously you want to exclude ICH, intracerebral hemorrhage, review the contraindications we talked about, and basically always reevaluate if the patient's improving rapidly. These are the contraindications for ischemic stroke. Signs of bleeding, basically any kind of intracranial or intraspinal surgery within the last 3 months. History of bleeding in the past, uncontrolled hypertension, seizures, or there's active GI bleed, history of brain tumors or any kind of malformations in the brain or any kind of blood vessels, or known bleeding diathesis, or warfarin use. So these are all listed. I mean, you don't have to memorize everything. You basically bring out a list of things. And a lot of stroke protocols has this listed as well, including the NIH score. So this is from up to date. And basically, just kind of a couple of things I want to mention. One of the studies recently that was published that basically made the 3 hours pushed back to 4.5 hours. It's called the ECAS-3 trial. And basically it talks about some exclusions based on that trial. So they want to caution you in terms of lysing somebody above 80, because during that trial there was no one actually enrolled above 80. So age is basically a risk factor for bleed. And at this particular time, when it's like beyond the 3 hours, the rate is higher in terms of bleeding. So always, you don't want to make the decision alone. You want to call the neurologist and basically talk it over whether the risk and benefits is there. And like I said, always talk to the family. Anybody that has been an anticoagulation is also a contraindication, no matter what their INR is. Any kind of history of diabetes and previous stroke. You want to talk to your neurologist about this. So those are the 3 things basically that's added as a cautionary exclusion criteria in the 3 to 4.5 hours. And also an NIH score greater than 22 is a high risk for intracranial hemorrhage. And these are the things that you want to talk to your neurologist about, whether you go ahead and lyse a person or not.
Any anticoagulation including aspirin or Plavix?
Just warfarin. Okay. Warfarin, yep. And some of the go ahead, Tony.
Well, up to date article doesn't it talk about, or I guess wrong, talk about the combination of TPA and something else causing like this. So the TPA by itself, like 40% chance or 60%, but if you combine the 2, I think it's like argatroban or what are the other ones, combine the 2, it's a 5% increase. Is that something that's become more macrolipid to study? So
Are you talking about in terms of lysing a patient?
yeah, like a combination of both. They have like the combination of 2 has like 5% for more better results after that.
Well, the only approved thrombolysis is alteplase. In a clinical setting, basically that's all you use. Now, there might be trials out there where they're combining a direct thrombin inhibitor with TPA, but that's pretty gutsy, because the bleeding rate's going to be very high in those combinations. So there's studies right now saying that there's really no approved thrombolysis in terms of using it intraarterially. So a lot of the surgeons are using urokinase, streptokinase, alteplase, and giving it intraarterially. But I've never heard of argatroban as a thrombolysis, though, in conjunction with TPA in a clinical setting.
What if they come in on Lovenox?
A contraindication. Yeah. So probably more so than the heparin. So, any other questions, guys? Mm-hmm.
Thank you. INR of 1.7. So if they were on warfarin and the
Mm-hmm.
INR was lower than that, you could
In the 3 hour to 4.5 hours, anytime they're on Coumadin is a relative contraindication that they're calling. But in the 3 hour, there's a cutoff. I think it's 1.5, or less. Then you could go ahead. So the 3 hour one is the one that's basically high. The rates of bleeding is not as high, and a lot of studies were done on that. And so this new 3 to 4.5, there's a lot of controversy still, and a lot of times, and according to literature, a lot of the ER docs in particular are very, very hesitant in giving TPA. I think of all the candidates, only 10% of patients receive TPA, and the most reason that a lot of the emergency physicians give is that, of course, they're afraid of bleeding. It's a legitimate concern, but I guess what we're trying to do is that promote education that the bleeding rates are actually not as bad as opposed to the benefits that you could get, as long as you follow the protocols. So sometimes in the CT scan that you do, there could be signs there that actually the infarct is so much bigger. So like, for example, if there is cerebral edema or mass effect, now these are things that would probably predispose the patients to bleed if you give TPA. So those are things that I would not initiate TPA without contacting either a neurosurgeon or a neurologist that's on call for you. So these are the things that we talked about with the ECAS-3, and those are the things that basically they're talking about. I know in the up-to-date it says that any kind of anticoagulation. It's weird because some of the studies that I've read, it would say anybody who's on anticoagulation, you just don't give it 3 to 4.5 hours. And some of them would say less than 1.7. And the 3 hour ones, it's less than 1.5. So what do? We basically maintain a blood pressure less than 185 or 110. And we try not to give TPA if it's above that. And the dose is 0.9 mg per kg with a maximum of 90. And 10% we give as a bolus. And the rest we infuse over an hour. So no IV sticks or Foleys or central lines in the next 24 hours, no antiplatelet therapy, no heparin sub-Q. So basically prior to TPA, you want to put in all the lines. Where would you put the line if you had to put one in? You'll put in a IJ, subclavian, or femoral line. So femoral line is probably the best. It's compressible. I guess you could argue you could compress the IJ. I probably wouldn't do that. There's an airway issue. There's a comfort issue, and then if there's cerebral edema, the venous drainage is altered. So femoral line is the best line to put. How about if you TPA somebody who has actually hypoglycemic, right? That's always what if this is not a stroke and I give TPA? What if it's a seizure or a migraine, you know what I mean? Like a Reglan responsive stroke or a D50 responsive stroke, you know what I'm talking about? Like a Lasix responsive pneumonia, that issue. So what happens when you TPA someone that is actually not having a stroke? So what is the biggest fear is the bleed, right? And somebody who didn't really have or didn't need the TPA. So what are the stroke mimics? Number one or number two, things that actually get lysed as a stroke mimic is seizures and migraines. So Todd's paralysis or patients that have migraines with a neurological or focal deficit. Some people have hypoglycemia and inadvertently nobody checked the AccuCheck and they get a TPA. But these are the things that could do that. Hypoglycemia, seizures, infections, which I would be afraid to TPA an infection, especially if it's a herpes encephalitis, and then you actually bleed all over. Multiple studies have shown that if you TPA these patients, there's actually no one has had a bleed. A lot of times the NIH score in these patients are actually in the 8s. So, low NIH score, they have intact blood vessels and their brain parenchyma is intact, so there's no bleeding. So a lot of times they advocate that if you're not sure, I would probably give a TPA. Always discuss with a neurologist. What if you had a TPA and they bled? So logic dictates basically discontinue the TPA, right? Repeat the CAT scan, redraw the labs, and always be mindful that you always have to draw it from the pre-existing IV if you can, because of course if you stick another site, it will bleed. And you would consider reversal agents, FFP, cryoprecipitate, or platelet infusions. Factor VII is one of them. Always consult neurosurgery and expedite transfer if you can. Well, just the bread and butter things that we do other than the TPA. It's basically airway control, fever control, blood sugars, seizure control if they're seizing. Is there a question about anticoagulant therapy in patients who are stroking? So give oxygen if they're hypoxic, obviously. Give antipyretics. There's no role right now in hypothermia in somebody who has a stroke. And then with the sugar, obviously, if they're hypoglycemic, that is really bad for the brain. You know, you would try to avoid that as much as you can. But hyperglycemia is bad as well. But what is the kind of like the line to walk? Probably 120s, 130s, 140s. A lot of the recommendations sometimes they would say anywhere above 140 to 180 you want to start treatment. And you treat with fluids, which is normal saline and insulin. There's a lot of therapy in terms of blood pressure control. You could use labetalol, you could use nicardipine, and you know recently it has come to vogue that we use nicardipine as a blood pressure control. They don't advocate you using nitroprusside. It's really good in lowering the blood pressure, but it has changes in the dynamics of the brain in terms of like cerebral edema. So labetalol only or nicardipine. There is no role in giving prophylactic anticonvulsants to somebody with a stroke. If the patient had a stroke and they're seizing, then that's when you do it. But you don't give Dilatin load or put somebody in an Ativan drip just because they had a stroke. What do we do with these patients who have atrial fibrillation, might have an embolic stroke? What do we do right there in the ER? Do we start heparin? I would not start heparin on someone who had a stroke that's suspected to have a cardioembolic event without consulting neurologist and cardiovascular and cardio. Okay, and always you don't give heparin after you give somebody TPA in that first 24 hours. So just don't do it. There's also questions now whether somebody comes in with a stroke, whether they have an advantage in terms of laying them down or putting them in a third-degree angle. So back in 2005, a group basically kind of explored this, and they noticed that if some stroke patients, if you lower them flat, they actually have better perfusion to the brain. I mean, you could try that in patients who are able to maintain their airway, they're not gagging, they're awake, they could tell you that they're choking. That might be something that you want to do. But in terms of convention, third degrees is the most advocated position. It's neutral, it prevents venous, it provides venous drainage and decreases some of the vascular congestion in the brain. And of course, patients who are like aspirating or having respiratory decompensation. Now there's some studies now about all these other adjunct therapies in terms of patients who are having a stroke, and these are all directed towards that cytokine cascade that we talked about earlier. Preliminary studies have been shown that use of minocycline has an anti-inflammatory effects to the edema of the brain. So these are all still in the works. This is, as you can see, it's in 2008. These are all preliminary stuff. Minocycline has been used in patients with MS, and there's some suggestion that maybe they improve cognitive function and decreasing the edema and the cells, but it's not approved yet as a clinical therapy in somebody who has a stroke. What about patients with a spontaneous intracerebral bleed? So about 10 to 20 cases per 100,000. And of course, as we age, we also accumulate amyloid and you have chronic hypertension. These are all things that would contribute to this, and mortality rate's pretty high, 50%. Without being said again, ABCs, BP control, send a patient to somewhere where we could do ICP monitor, reverse coagulopathy. Okay, decrease the swelling by using mannitol. 0.25 mg per kg, IVQ 6 hours for somebody who's got osmolarity less than 310. Okay. A few words on subdural. A lot of times these subdural events didn't happen right there when they come to the ER. It might have happened maybe 2 or 3 days later, and the parents or the patient's family are like, well, how come grandmom's a little confused today? She's a little bit more sleepy than usual. And they come in, and we think all the time it could be urinary tract infection. And I just want to make sure that to remind us that make sure we also entertain the thought that maybe they had fallen at some point and nobody's mentioned it to the caretakers, and to make sure that we don't forget that this could be a subdural bleed, that we get a CAT scan. Sometimes a lot of these patients don't really have the classical presentation, headaches, visual changes, or vomiting. They just have sleepiness and confusion. Or sometimes, if we're lucky, they would have some seizure-like activity that would prompt us to do a scan, or some focal signs. How about aneurysmal subarachnoid bleeds? 78 per 100,000 patients in the age bracket 70 or higher. The average age of presentation is about 50 years old. And somebody who's greater than 70, there's about good outcome in 25% of the patients, as opposed to somebody who's less than 40, where the outcome is about good outcomes of 73%. There's also higher rebleeding rates in somebody that's older than 70, and about 16% of the time, and they're equally as lethal. So most of these patients basically get blood pressure control. Always the question is, what blood pressure do we aim for? So MAP of 130 or systolic of 140 or less. Nitroprusside, as I mentioned earlier, basically dilates cerebral vasculature, increases the ICP, so I probably wouldn't use that at all. Never seen it used at Lourdes. I've never seen it used here. All the time, these patients require multiple CAT scannings to basically evaluate the progression of the bleed. CAT scan is about 93% sensitive in finding out there's a bleed or not in the brain, and the 7% or so, that's what we do DLPs for. How about these things all the time? We get these patients that come in, I'm dizzy, and a lot of times we want to make sure we kind of talk to them and find out what dizzy means. I had a patient yesterday, she said she's dizzy, but she actually meant that she has nasal congestion. And I had a patient the other day who said he's dizzy, but he has basically a sinus pain. Not even congestion. I'm dizzy. Well, what do you mean? I have this pain right here. So, a lot of patients of this preconceived notion is kind of like an umbrella term for a lot of things. So make sure it's not dizzy vertigo, room spinning, or dizzy pass out. So a lot of times we get a lot of geriatric population that come in complaining of dizziness, and then make sure you just talk to them, describe the two, because there's two different entities there. Somebody's coming in with vertigo, you might go one track and somebody says, I feel like I'm going to pass out, and most of the time it's probably a cardiovascular symptom than the cerebral one. Okay, so if it's peripheral, it's acute onset. There is severe nausea and vomiting. And make sure you ask if there's tinnitus or some hearing loss. Basically, you want to distinguish vertigo from peripheral versus central. Clinical exam is really not that great in distinguishing the two. So if you just go ahead and just do an exam on a patient, you probably miss 25% or more of cerebellar ischemia. And some of these things are cardioembolic that needs evaluation in the as an inpatient stay for telemetry or echo. So the bottom line is, somebody that's geriatric population, low threshold for admission, and low threshold for CT scanning the brain or MRI. So peripheral vertigo, you get the motion sickness. It could be benign positional paroxysmal vertigo. It could be otitis media, vestibular neuritis, Meniere's. It could be from the medication, from all the Vancos we ordered, or it could be central vertigo. It could be from, a lot of the older population also drink. So, and we've seen some 60-year-old doing cocaine. So, you have to make sure that you ask questions in terms of alcohol use. And this could be seizures or migraines. But you don't want to miss a cerebellar stroke. So, the biggest thing in this patients here, the most important thing that we could emphasize on is that patients with a cerebellar stroke cannot walk at all. So it goes without saying that when you're evaluating someone in the ER, make sure you walk them. You know, I personally don't do it 100%. I should do it 100%. We should all do it 100%, but gait testing is mandatory. So if it's peripheral, you could do an Epley maneuver. You could do some meclizine, benzos, some antiemetics, basically some steroids if you think it's vestibular neuritis. What is an Epley maneuver? Somebody is taking your boards, the clinical exam one. They might ask you. I had actually a vertigo patient as one of my patients during that time, and I told him I'm going to do a Dexter whole pike maneuver. So I can't believe I passed. But anyways, this is how you do an Epley maneuver. Okay, you have the patient sit down, tilt the head 45 degrees, then you lay them down, and then turn the head the other way 90 degrees, and basically sit them up. And that is to dislodge the otolith that's in the inner ear. One of the attendings in the Washington Township internal medicine came down one time because we want to admit someone with vertigo, and they're very, very proud and say, listen, I'm going to show these ER doctors and how to dislodge this stone in the ear by doing an Epley maneuver. Well, he comes in the room, does this thing, and the patient throws up on him. So the bottom line is make sure if you do this that they might throw up. So how about CNS infections? Basically, as we get older, our immune system is not as great as when we were younger. It could either be from malnutrition or it could be from just immunosenescence. Patients that come in with infections of the brain are usually sometimes confused, and all these non-specific things basically that they come in with makes a lot of our jobs a little harder. They could just be, it could just be a fall. It's like, oh, grandma's been falling a lot, and I don't really know why. They don't have a fever, or they don't have a white count, because they have blunted fever response, and sometimes it could even be hypothermic. So the largest spikes of meningitis basically occurs when somebody is an infant and somebody is 60 years old. And of course, the reason why that is that an infant also have immune deficiencies because of aging. I mean, because of that stage of their development. And as we get older, we also have the same thing. So there's about 2 to 9 cases per 100,000. And a lot of times diagnostic delays are common because a lot of times when they come in, they also have another infection source somewhere. I mean, a grandma comes in with pneumonia and nobody really thinks that there's also infection in the brain. So we treat. That's why I would probably give everybody Rocephin. It's kind of co-treat the CNS abnormality. But anyways, the classic triad that we come to know, fever, nuchal rigidity, altered mental status, basically 46%. So it's kind of like a flip of a coin. But the absence of all three is really good in determining whether, in excluding someone. But nuchal rigidity, right? How would you evaluate an elderly with nuchal rigidity? A lot of times they got arthritis. They may have Parkinson's disease, so they have a chronic nuchal rigidity. 57% of the elderly that have meningitis have stiff neck. 12% of them have positive Carnegie signs, but they're healthy. 18% has Brudzinski and they're healthy. Okay, but in 57% of patients with quote-unquote meningitis, 35% of them could have no CNS infection. So it basically goes to show that you probably need to do a TAP. And these are the bacteria that predisposes us when we hit 50 or older: strep, meningitis, Neisseria, listeria, and some aerobic gram-negative bacilli. How about epidural abscess? So a lot of times the diagnosis of these things are delayed up to 75%. And the reason for that is that low back pain and back pain in general is pretty prevalent in the elderly population, either due to musculoskeletal problems, degenerative joint disease. So it's really hard to suspect this thing. And a lot of times, like we said, they don't have a fever response, they don't have an elevated white count. So a lot of times we have to make sure they don't have an implanted device. They just didn't have a procedure recently that would basically have some sort of a spread of bacteria to their spine. And palpate the back. Make sure there's no fluctuans in there or any kind of lesions that are present that you might have missed otherwise. The rule basically is that antibiotics and expedited transfer to somebody that has neurosurgery. A lot of times patients that come in with a cervical abscess in their spine, they might need to be intubated, because a lot of these infections could spread and involve the airway. And that's about it. Do you guys have any questions? It's kind of like a brief overview. All these neurologic emergencies, there's a billion of them that you could include in these things.